So here you're watching drug-induced sleep endoscopy with this monitoring in a 47-year-old male with history of severe obstructive sleep apnea. You can see he's got a gross DNS on the left. There's no space for me to go inside, and you can see the turbinate hypertrophy on the right, a gross turbinate hypertrophy. Sinuses are clear on the CT scan. His body mass index is 29, so he's not obese, he's overweight. His apnea-hypopnea index on the sleep study is 41, so it's a case of severe obstructive sleep apnea, but majority of the events are hypopneas. 38 out of 41 are hypopneas. As you can see, the nasopharynx is almost clean. The salpingopharyngeal folds are also grade 0 by Agrawal's classification. And at the base of 85, 86, which is not still in the perfect range, we want it to come below 80. We are starting to see a multi-level collapse. But as was seen on the sleep study, majority are hypopnea and not complete apneas. So till this point, we are not seeing complete apneas. Is sleeping supine, his mouth is closed, and we can see a multi-level collapse of palate and epiglottis, which is incomplete, which is obviously not complete. And that's what was seen on the sleep study as well. Snoring sound is not his biggest problem. His biggest problem is disturbed sleep. He feels some pressure on the chest. So now the BIS is in the correct range, 74. And yet there is incomplete collapse of the soft palate and the epiglottis. Now we are seeing a complete collapse of the epiglottis, the primary epiglottic collapse. What I'm doing now, so possibly this is where he feels the choking. But as you can see, the epiglottis is also not remaining collapsed for very long. It's opening up. With every inspiration, it is closing, but then it's opening up. The palate is definitely collapsing incompletely. Now what I'll do is I'll lift his chin and see what happens. Very gently I'm lifting his chin. That improves the collapse. I'm not lifting the chin too much. I have just supported the chin, and that improves the collapse. Now from the epiglottis, the collapse has shifted to the soft palate, and you can see the tonsils coming together. When I leave the chin back, again the epiglottis starts to collapse. So he will definitely do well with a mandible advancement device, or even a chin strap with extended neck will help him to some extent. What he definitely needs is a nose procedure to open up the nose, but that will not eliminate his collapse of the pharynx. That is again for sure. The pharyngeal collapse will not be eliminated, and now you can see I'm trying to keep his mouth gently closed, and you can see his tonsils going and touching at the back, the posterior pharyngeal wall. So definitely the pharyngeal aspect is also there. Now this is the correct level of BIS 75 and he's sleeping supine. Now what I'll try to do is I'll turn him on the left side. Can you turn his head to the left? Now we are turning his head on the left, and we'll see what is happening. So we'll see what will happen when he's sleeping on his side. So with sleeping on his side, you can see the epiglottic collapse has become little lesser. The palatal collapse has not become any significantly different. Palate is still collapsing, but epiglottis is not. So after the nose procedure, if he sleeps on his side, he will definitely be better in terms of the epiglottis. Then that means he will not require a mandibular advancement device, because if he sleeps on his side, his epiglottis is not collapsing, and anyway, the mandibular advancement device was not going to help too much on the soft palate. His tonsils are coming closer, so there is an option for a palatal procedure, a simple tonsillectomy or combined with suspension bridge pharyngoplasty for the soft palate part, and sleeping on his side so that he would not require a support for the epiglottis. So mandibular advancement device may not be required if he sleeps on his side after the nose procedure, especially if we have also performed a palatal procedure. Alright, so thank you for watching. 47-year-old male, AHI of 41, BMI of 29, majority being hypopneas. Thank you.